Hello, callers. You're listening to the Chronic Disease Management webinar hosted by BHT. This is Justin Bodeju on staff with Better Health Together. Today we have Dr. Ron Stock who's going to walk us through some slides and give us some guidance on the chronic disease project for our transformation efforts. Dr. Stock, I'm turning it over to you.
Great. Thanks, Justin, and good morning, everyone. I suspect there will be a few more people that will be coming on. I see that we have a chat box with the webinar today, and it would really be great if you wouldn't mind maybe even typing in your name and your role in this project and title would be great. It'd give me kind of an idea of who's on the line this morning. But let me just introduce myself. I'm Ron Stock. I am a clinical innovation advisor to Health Management Associates, which is the organization that's providing some technical assistance and guidance to Better Health Together. I'm a geriatrician and family physician by trade. I've been faculty in the Department of Family Medicine at OHSU. Previously practiced for about 25 years in Eugene, and have been interested in health services research and particularly interested in redesigning the clinical delivery system for vulnerable populations. Certainly, much of my career has been focused on the frail and vulnerable elder population, but in the last 5 years, I've had the privilege of being Director of Clinical Innovation for the Oregon Health Authority in their Transformation Center to help with Medicaid reform in Oregon. I have a couple of other projects that you all might be interested in at some point, but I also provide advising and accountability to develop Project ECHO in Oregon. Certainly Washington has been far ahead of Oregon in that regard, and we might chat a little bit about that today. And then also the Comprehensive Primary Care Initiative, which is the largest national project to redesign primary care practices around Medicare beneficiaries. What I'm hoping for today, my aim with you all is to help you think through about how you want to organize and focus your plan to reform care in your community. This is certainly an area that I've spent about 30 years thinking and working on. I think that what I'd like to do this morning is start off with a little bit about the chronic care model and make sure everybody's on the same page about what that model looks like, that particular framework. I'm going to share 4 lessons that I think are critical lessons that we've learned over the last 20 years about the chronic care model and things that work and don't work. I'm going to share a few slides around some interventions using the chronic care model that have some evidence, and I think that are very important for you to think about and focus and have some discussions about as you deliberate your plan. And then finally, I'm going to give you a tool for you to think about using in your deliberations as you talk about how you implement the chronic care model in your plan. And it's a pretty simple tool that's been used in a number of other organizations with the chronic care model, and hopefully that can be helpful for you. So next slide. So I think it's always helpful to start with a definition. This actually comes from healthcare.gov. And what is chronic disease management? Well, if a patient or anybody were to go to the healthcare.gov, this is what they'd find. It's an integrated care approach to managing illness, includes screenings, checkups, monitoring, coordinating treatment, and patient education. It can improve your quality of life while reducing your healthcare costs if you have a chronic disease by preventing or minimizing the effects of the disease. So what does this mean in terms of Better Health Together and the communities in which you all reside in? So I went to the templates for your application, and I think in order to sort of narrow this down for for you all in terms of what your aim is going forward. This is what you probably all have memorized this already, but what BHT is focusing its MTP initiatives on the complex care population, Medicaid beneficiaries with one or more chronic diseases, and co-occurring mental health and/or substance use disorder. And BHT has identified diabetes as a priority chronic disease. So BHT is already sort of focused on a particular population, and I think this will help you in your thinking about this. Next slide. So about 20 years ago, I was sitting kind of in the same seat as you all were. In 1997 was the first launch of the chronic care model by Washington's own Ed Wagner from Group Health and Don Berwick from the Institute for Healthcare Improvement. I wasn't sitting in a webinar, but rather in a ballroom in Dallas, Texas. And there were about 40 organizations that were exposed to this model for the very first time. At that time, it was introduced as a consensus-driven model. We had at least 10 or 15 years of data that told us what were the best was the best way to provide care in chronic conditions. It's really been over the last 20 years, this has continued to be a framework to think about it. It's not a prescription. It is a way to think about what you want to accomplish and to make sure that all of the elements that we know would provide the best care possible are provided. And so I'm going to just walk through this with you. I apologize for those who've maybe been through this 100 times, but I think it's helpful to think about what this model is really trying to accomplish. What I want you to do is I'm going to, since I don't have a pointer, I'm going to have you focus, try to direct your eyes to the bottom line, and that's really improved outcomes. And you can really change those words to whatever you want to make that. I mean, you could change that to improving diabetes outcomes in the SPMI population, for example. You could say improved asthma in children. You can change that to whatever aim that you would like it to be. But that really is the bottom line of what we're trying to accomplish through this framework. And in order to accomplish that, you need to have a productive interactions between the patient, whether that be a child, an elder, someone with a mental health condition, and a team that is really prepared and proactively prepared to interact with the patient. So you really have two pieces there that need to happen simultaneously, and this could be in the practice setting, this could be in the hospital, it could be in a number of different settings, but it really is that interaction between the person with the condition and the practice team that really is what leads to improved outcomes. In order to have a productive interaction, you really need 4 elements that help support that interaction. And that's sort of the next level up in the sort of the green space there. And what the model says is that in order to have informed activated patients, you need a self-management support system present for them to be informed and activated. You need a delivery system design that meets the patient in the best place at the right time. And that could be the one-on-one visit in the office, but it could also be a group visit. It could be a visit in a senior center or a YMCA. It could be, you may have a delivery system design that focuses, that uses maybe other healthcare providers like nurse practitioners or pharmacists or social workers in the design. And the design is in a way that does screening and provides information about what the population that you're working with. It requires a productive interaction, requires decision support. You have a guideline about what the best care for diabetes is, or asthma, or whatever the condition. Is that well known to the staff? Do they know about that, about those guidelines? Do you have good access to specialty care? Can you get someone in immediately? And do you have that kind of capability? So do you have the kind of decision support for this? And then finally, a clinical information system that helps with the communication between the various clinicians or clinic entities, and in these days also how that connects with the patient themselves. Those four elements all are supported generally through healthcare organizations. So you're just kind of moving up the slide there, if you will. And the healthcare organizations could be your practice, could be a larger system like a Kaiser or a Providence or whoever, and how are they supporting those four elements? And generally, the health systems or the practices, you all exist within your own community. So there is a larger community in which, a context in which you exist, and then how do you leverage those resources within your community that might help support all of those? So that is a sort of a quick overview of what really the chronic care model is all about. And as you look through your application template, or you look through the materials, you'll see that these elements, the 6 elements in those materials, are all reflected in this model. So what I want to do next is share some lessons that we've learned about this model, and maybe I'll just take a pause here for just a second and ask if there are any questions. Justin, you want to open up the line? And folks, feel free to ask questions. You can, I'll stop intermittently, but also feel free to type type a question into the chat box, and both Justin and I will watch for that. So let's just open the lines for a second. Justin, are you still there? Hopefully I haven't lost anybody.
Yep, the line is open, Ron.
Great. Okay. Well, hearing none, let's move on. So lesson 1. So next slide. So lesson 1 is a lesson that I think you see reflected in a lot of the materials around the chronic disease management, and that is the focus on patients, and that the importance of really they being the North Star of our plan, of whatever we do. This is my North Star. This is my picture of my father in 1956. He's standing in front of that house in the background is the house I grew up on, and the farm in eastern Nebraska. He's standing in a field of Nebraska 28 switchgrass. He was an innovator in terms of bringing prairie grasses for soil conservation in the 1950s and 1960s, in large part because of his chronic conditions. This guy had more chronic conditions than you could shake a stick at, but in the 1950s he developed pretty severe back problems. He always attributed it to riding tractors in the 40s when they were the wheels were primarily steel because of the need to contribute rubber to the war effort. But as it turns out, he ended up having Crohn's disease, and his back and joint and arthritis symptoms were probably all related to his colitis. But he needed to find another way to be a farmer, and so he proceeded to move down the road of changing his farming practices to prairie grasses, which didn't require long 10-hour days or 12-hour days on a tractor. So I've learned more about chronic disease from him than anyone else. He lived with diabetes from the age of 40 until this last year. He passed away at 95. And he also had asthma, hypertension, Crohn's disease, as I mentioned. And I think the other lesson that was learned is the importance of staying centered on what was important to him and the benefits of what he thought he needed to do in order to manage the chronic disease. He actually learned to give himself his own insulin shots 6 months before he passed away. So a pretty remarkable lesson of not giving up on people despite their age or intelligence or whatever. But I think the lesson that we've learned over and over again, and you'll see this in a lot of the materials around chronic disease management, is the importance of staying patient-centered and involving patients, their families, in whatever plan you put together. Next slide. So lesson two. Lesson two is a lesson that I think we may finally be learning. So this is actually a cartoon that and I'll just read it to you. It says, people were always telling Franz he had room for improvement, so he decided to build on a sun porch. One of the things that we've have a long history of doing in the healthcare field is looking for that golden grail in which that one lever that we pull that makes everything better. And I think we over the last 2 or 3 decades, we've been looking for that in our own healthcare system. If we could only get the right payment methodology, everything would be fine. If we only had built the right program around nutritional care or around quality improvement. If we only had the right building that would provide care and access to folks, then everything would be improved. We only so Franz gives us the message that, just building on a sun porch doesn't necessarily mean that you're going to improve. And in fact, we've learned over the last decade that changing, particularly chronic disease management, requires multiple levers being pulled. It requires us paying attention to the patients and their needs and preferences. It requires us to have systems in place that coordinates care across organizations. It requires us to have the right payment methodology, and that just changing one of and it requires us to have an EHR. Many of us thought, and many people felt like, well, if everybody got on the electronic medical record system, we would improve our healthcare system. Everything would be fine. And what we've discovered is that we need to pull multiple levers at the same time. And the chronic care model, I think, allows us to think about what those different levers are and to think about pulling them all at the same time. So next slide. So lesson 3 is build on known evidence. So as I mentioned, a lot of what we're doing is based on evidence that we knew 20 or 30 years ago. We've known that many of the elements of the chronic care model was important or has been important to implement, but we just haven't been able to implement them. And it's I put this up here. This is a summary of the elements of transformation at the front line. That an article that was written in JAMA, actually back in 2008, I think, it says 2009, by Carolyn Clancy and Pat Conway, both general internists who have been great leaders at the federal level about advocating for chronic care and healthcare in reform in general. But they outline 4 elements that we've known needed to occur for a lot of years. You know, first of all, we need to invest. Things won't just happen if we don't invest in some very key drivers, including quality improvement and payment methodologies and HIT, clinical training and workforce development. These are all elements that we need to invest in. They don't just happen automatically. And the second element that we know is that we need to involve the clinicians at the front line. They need to be part of the solutions. I would encourage you all in your deliberations, whether you're a partnering organization or a collaborative, that you involve those who have been identified as champions and are interested in engaging and engage them in the process of developing this solution. Third piece is aligning a payment system that supports these elements. I think that in many ways the managed care work in the 1990s failed to do that, and we've learned a number of lessons through the years about the importance of aligning payment, and we're starting to see that now. And then finally, I've not seen a practice or a reform effort in an organization that didn't have a champion. And I guess I think we tend to underestimate the importance of that, but a champion is needed, particularly at the front line, to help deliver and support the message that you all. I suspect that many of you on this call are maybe one of those folks, and I would encourage you not to underestimate the importance of that role. So let's go on to lesson number 4. So lesson number 4 is that we know that we need data and good information to build our processes. So Justin, are you there?
Yes, I am.
Okay, can you move to next slide, please?
Oh, sorry, I got frozen there for a second.
Okay. There you go. So lesson 4 is being data and information driven. I think that those organizations that are intentional about collecting information, having a clear idea of what of their environment, of their community, what exists within their community, and using data, either quantitative data about the demographics, or using qualitative data about interviewing through focus groups or direct interviews with patients and clinicians, and using that information to help develop their plan. Those organizations tend to move through the reform process more quickly, and I think in a more satisfactory way. So I pulled a few slides about BHT and your regions. Some of this many of you may have already seen. Lisa Angus from Providence Core, I know, shared some information last Friday with some, if not all of you, on the phone. And she and I talked a bit, and I pulled a few slides from that. But also, we talked a little bit about, well, what does it look like in BHT in terms of the number of folks. So I put this slide up here, and a couple of things. So these are the Medicaid members' health status by county. I'm not entirely certain where this came from, but I believe it was state data. And what you'll see is that in the blue bar is the percent of folks, of at least a quarter to a third of the population, Medicaid population in your counties, each of your counties, have at least one chronic disease. I think what's interesting here about this slide is that there are some differences, particularly when you look at the percent of mental health that's with the yellow bar, the percent of folks with mental health or substance use disorders and one chronic disease. I think understanding, I think what this does is it provides you probably more questions than answers about, well, what are those chronic diseases? What are those mental health conditions that are present in this population? Why are there many more in folks in Adams County as opposed to Pend Oreille? Why, there are a number of questions here that you might want to ask and dig further that might give you an idea about what are the kinds of interventions you want to employ. So next slide. So the next few slides are some data that was pulled from the survey that maybe many of you actually filled out. I think Lisa may have shared this with you last week, but what we know is that from this survey, there were 45 organizations that signed MOUs, and that all of them provided information, which I think is great. And as you can see here, that most of the responses came from Spokane County. Next slide. When you look at the respondents, it's an interesting mix of clinics, and you see that the services provided across these organizations include the primary care, both primary care and mental health. 14 clinics providing primary care services only, and pleased to see so many were providing both behavioral health and primary care services. Next slide. When asked specifically questions around chronic disease management practices, I think it very encouraging that most clinics were using care coordination personnel. Again, I would probably dig into that a little bit deeper at some point about, well, were these folks that were primarily that was their role, or did they have multiple roles, et cetera. About a third of the practices have chronic disease registries, which seems to me to be a great opportunity for many of you. When you look at the chronic care model element in the table there, a couple of things jump out at me, and I'll just point those out, and you can look at these slides later or at the data later. Certainly the practices that have both primary care and behavioral health have many of the elements in place already. The other that jumps out to me are the culturally sensitive care programs or initiatives. And again, this might be an opportunity to think about this maybe being a gap for you all, and thinking about how you might consistently or standardize culturally sensitive care programs in your region. Next slide. I wanted to include a couple of questions I asked. One was about how well the practices or clinics that would be participating were able to actually develop chronic disease registries. And many times you use electronic means to do that. And so this slide kind of helped provide some information about that. It appears that identifying patients and generating lists of patients are being done both electronically, more so than probably paper and pencil or Excel spreadsheet, but it's being done in 80+% of the practices that answered this question, which is a very positive thing. But the question about how to organize this and whether there are some electronic means to develop these lists going forward, and using IT as a population management tool is another opportunity. Next slide. So I wanted to ask a question. In talking with Lisa Angus about this, about paying attention to, and again, falls in the idea, the lesson around being patient-focused and patient and family-centered, or what are the social determinants of need issues. And what was interesting about this data was that the same three occur in both in probably a more urban setting of Spokane County, and the rural counties, however, the order in which they occur are different, and most of you won't be. I wasn't surprised by that, but I thought that was interesting. What this did bring up for me is actually a non-medical need that isn't on here on this slide, and that has to do with literacy and education and understanding of their chronic conditions with the patients. I would just a brief story. A number of years ago, or about 3 years, I provided group visits in a volunteers in medicine clinic in Eugene. You may have, I don't know if you have volunteer in medicine clinics in your region. These are primarily folks who had no health insurance or Medicaid, and weren't getting access to care. But for about 3 years, I ran group visits for diabetic patients and on a monthly basis, a nurse educator who specialized in diabetes and I would meet for 2 hours once a month. And generally we'd have 8 to 10 in these groups. But there was a young woman about 23. She was working on her GED, who had diabetes and type 2 diabetes, and just was not. We were just not getting good control, including relatively moderate doses of insulin. And it was really not until the third session that I asked her about how actually describe to me how she cooked her meals, and she said, "Well, I don't really cook." And I said, "Well, would it be helpful for somebody maybe to go to the grocery store with you?" And as it turns out, she had never actually really gone to a grocery store before. She worked in a 7-Eleven, and she walked to work or used public transportation, and that she felt really intimidated by going into grocery stores, but that she purchased most of her food actually in the 7-Eleven store. And so it suddenly became pretty clear to us that the intervention here was to help her understand the importance of nutrition and helping her feel less anxious about walking into a grocery store and reading labels, et cetera, et cetera. But it's a good reminder that we need to pay attention to those, and that sometimes those are the simplest interventions, are sometimes the most important ones. So next slide. So these are the 4 lessons that I wanted to share with you. And over the next few slides, I just want to talk a little bit about interventions that we have evidence that work. And I've divided them up in terms of at the clinic setting for patients and families, and then finally kind of at the health system and the community level. These are really suggestions. I could probably name maybe another double the number of these interventions, but these are the ones that I think are the most important ones. One of the things that we've discovered here is that having someone identified and even assigned to a medical home, particularly those that are integrated homes, with behavioral health, are homes that are that the outcomes are better. This seems to really make a difference. We recently looked at this in Oregon in terms of those folks who were assigned a patient-centered medical home and compared the costs and discovered that there was about over a 3-year period of time, there was probably about a $250 million savings in terms of utilization and costs to the state as a result of that. The second is that having somebody really in charge or looking at the population that you're interested in, and these generally are care managers or care coordinators, particularly at the practice setting. The third place that I think has pretty good evidence about providing changes is working with the people who are in the clinic around improving their relationships and their teamness, if you will. This is an area of particular interest of mine, and we could do a whole session or two on that. In fact, I've done a 2-part webinar on team-based care and teamness for the patient-centered medical home work in Oregon that I think would be available to you all if you wanted to look at that or use that. The other intervention that we know that works is knowing, screening for and identifying in a registry who the population that you're really focused on. That being step one. Step two being then look at that list and to identify those folks who might be the top 10%, 15, 20%. In other words, risk stratify those folks who are at most at risk of having poor outcomes. And that is the whole process in and of itself. And I think that many practices, in my experience, have at times struggled with that. But we know a lot more about the risk stratification process and how to do that now than we did probably even 5 or 10 years ago. The last intervention that seems to really work in practices is being really transparent about the data and the quality outcomes. Data management in terms of collecting it and recording it and so on is always an issue in practices because some have better systems in place than others. But I think that the sweet spot here in terms of changing behaviors of the clinicians and helping patients is sharing this with the staff and patients in a way that makes sense to them. Many practices now are using dashboards. They make it very clear both in their break rooms in their clinics, but also sharing this out in the waiting room with patients. Next slide. I'm not going to, so this is a slide that I'm just going to direct you to the citation at the bottom. It's called Creating Patient-Centered Team-Based Primary Care. This is a relatively short paper. This was an initiative that I participated in. There were about 10 or 12 of us. We spent about 2 years talking about what are the key elements of team-based care. And this paper is pretty short. It's pretty succinct in terms of these are the elements. Again, it's a framework, kind of like the chronic care model is a framework, but this is a framework around team-based care. And I encourage you to look at this as another resource if you're interested in this. I want to just point out the foundation. If you look at that, the foundation of a medical home and a primary care practice, one of the foundations is a good relationship among provider team members, creating a foundation for good relationships with patients and caregivers. The importance of creating relationships in the staff is an element that we sometimes don't pay much attention to. We more focus on the processes within the clinic and less around relationships in the practice with the team members, whether it be a social worker or a pharmacist or the nurses and the physicians or nurse practitioners or psychologists or behavioral specialists. So, I think looking at this would be a resource that might be worthwhile for you. Next slide. So some interventions that work from in the context of patients and families. Most of you, I would assume, have heard of the chronic disease self-management classes, Living Well with Chronic Disease. Well researched. Many communities have these. I don't know what the resource is like in your communities, but this is certainly one of those areas as a collaborative or as BHT in making sure that this is available or accessible in your plan, I think is really important. Shared decision-making tools. In the last decade, there have been a number of tools that have been produced that have evidence in terms of helping patients decide whether they go on statins for their high cholesterol, how they make decisions around advanced care planning, a number of different decisions. I tend to use the one from the Mayo Clinic, and patients have found that to be really informative. But there are some tools that I think you might consider. Having a patient portal. Not all electronic medical records have that. I think that that's an important way of connecting with patients and they connecting back to the practices. An area that is emerging, many of you may know more than I know about this, but I've had a little bit of experience around texting, using texting and social media, texting in terms of reminders. We've used it down here, particularly for in the Medicaid population in pregnant women, to remind them of lab tests and appointments and so on and so forth, in terms of making sure that good prenatal care, and then rewarding folks for showing up for their lab tests or their appointments. We've used this in adolescents to text them about reminders around getting their vaccinations or their adolescent well visits, and rewarding them with iTunes songs and access to that, and found that to be very effective. So there are some tools you might think about to help with that. The other is the last one. You don't find this in your materials so much, but the use of patient and family advisory councils. This might be more at the health system level, but certainly in practices. Establishing a small group of patients, family members that can help advise the practice or the clinic around, and also be real advocates for the work that you're doing in your clinic, have been found to be very effective. Next slide. And then I think finally the interventions that work in the health system and the community, collaborating with the community organizations, American Diabetes Association, United Ways, the YMCAs. I think most of you are all well aware of that. Alzheimer's Association. We, in our clinic, because it was primarily a geriatric clinic, we actually invited the Alzheimer's Association to come in once a week, and they came in on Wednesday afternoons and would be available. So thinking about how you actually collaborate with some of these organizations might look a little bit different than what we might normally see. Practices change behavior when quality is incentivized. I think this is a major learning for us, is that when organizations and providers pay attention to their behavior changes and become they really pay attention when there's money associated with it. And I think that's an important lesson to learn. And this can be either at the quality, at some of the measurement levels that you're looking at in this project, but you might also think about how you support your own staff. You might think about individuals who might be interested in becoming health coaches, or want to learn more about motivational interviewing. So rewarding staff that want to help maybe support certain aspects of the plan you're trying to implement. The third here is transitions of care. I know that this was an option to focus in some regions of the state. But there's good evidence that really paying attention to transitions of care, particularly from the hospital and the emergency room to homes or nursing homes, really do reduce readmissions. And I would still keep that on the list of interventions that work. Leadership development, building workforce capacity, thinking about redesigning maybe some roles in the clinic that were previously pretty standard in terms of standard nursing, to maybe a role that is more around care management and care coordination, and begin to build that workforce capacity within your own clinic or setting is important. And then finally, Project ECHO has good evidence around, this is a telementoring process in which clinicians and sometimes teams from practices participate in weekly or every other week hour-long video conferencing with experts from maybe academic centers or hospitals around a particular topic. And it might be around diabetes care, it might be around hepatitis C, or psychiatric care management, which are some that we're participating in here. Next slide. So the last so these are some specific strategies. You'll find this in your materials. I would just say point out that it's important, I think, that when you think about the strategies you want to employ, that you use strategies that that somebody's looked at before and have studied. I think one of the important things to remember is that a smoking or tobacco cessation program that was extremely successful in Fort Collins, Colorado, may not be implementing it the same way they did in Fort Collins may not be the same way it's implemented in Spokane or Eugene or Seattle, but that the key components are usually the elements are the ones that you need to pay attention to. But these are some suggestions for you to look at. Next slide. I'm going to end with this driver diagram, and the driver diagram is a tool that I think some of maybe the public health folks think about these, I think they use a different term, maybe logic models. But this is one way in which you can have a discussion in your work group or in your practice or clinic about what you're trying to accomplish. So just looking at this, the aim, I put this together thinking, looking at the chronic disease and management and control as the primary aim, but you could change that aim to being one that's focused on diabetic patients with more than one chronic condition and a mental health condition, and have a different aim. And then the primary drivers are really the elements from the chronic care model. And then the secondary drivers are, for each of those primary drivers, there are a set of secondary drivers that are necessary in order to address that primary driver. And then in the fourth column, it's really the change idea of how you want to, what is it that you want to do? What's the intervention that you want to do to impact that secondary driver? The orange or whatever color that is are all suggestions that I put in myself, but this is where you might have a conversation about what are those change ideas that would address that particular that element. And then in the last column is what is the role of either at the collaborative level or the BHT level, what is the role to support that? I think it's clear that you're not going to be in the practice and have control over a lot of this, but there are certain things that you might be able to provide that would help incentivize or would help provide that support. So, for example, if motivational interviewing training is important, or mental health first aid is important for all the clinics to have, and you decide you want to do that, your role might be to provide train the trainer or provide those resources to do that. So I'm going to stop there. I'm going to open it up for questions, comments, is this, I guess my question I have for you all is, what does this kind of tool, would this be helpful for you? Certainly able to provide more information about that. And you're welcome to use any of these slides and use any of this driver diagram to help. So, next slide, Justin. So you can go ahead and list. So I listed some questions for you all to consider. And I might actually just reach out. Emily, I know you're on the line, and maybe from the work that you all are doing in Spokane, maybe talk a little bit about how you're thinking about this and any particular challenges or any information you might want from this group that would help your work group. But I put these questions out there. I think it's important to identify, do an environmental scan of your community, whether it's your county or your city or village, about what you currently have. How can you build on that, looking at the elements, and then where are your gaps? Where will you need help from the collaborative or the state or somebody else to help establish this? The third question I think is really helpful, and it occurred to me as I looked at your data that there may be some practices out there that have been doing this work for a while, and that they may have a lot to teach others. What we found is a very strong learning paradigm, and I think the attitude, the environment you want to create is a continuous learning environment that and allowing peers to teach other peers about what's worked in their community. So I'm going to reach out to Emily. Would you mind just saying a little bit about how you all are thinking about this particular element in the transformation plan?
Well, one of the things that I can think of, that I've been thinking about since you've been speaking, is in our current transformation plan that we have, at least in our group, the one piece that I feel like I guess we're missing is if you have any strategies or ideas that work to increase patient engagement. I think we have a lot of the programs, we have a lot of the systems in place, but the one piece that you were talking about was, making patients kind of responsible for their own care. And if you have any ideas or solutions around that, because I think when I think about the plan we've been writing, it's lacking some support for that piece.
Right. Yeah, no, I think that's and that's a challenge, I think, for everyone. I can just give you some ideas that I think other folks have found to be helpful. One is identifying and addressing or engaging folks not necessarily just in the clinic. So let's take adolescents, for example. So thinking about collaborating with school-based health systems. So there might be some engagement in schools. You might think about other programs where folks in your population might already be spending some time. And I think some examples might be relief nurseries or Head Start or WIC programs or other programs like that. Other communities have used community health workers to particularly in populations that tend not to come or access healthcare systems. So they use the community health workers to actually be outreach and go out and do a number of things, including screening for, say, diabetes or screening for depression. Folks that and then meeting them in the community. There's a RWJ has funded a number of programs now that are focusing on complex care patients using resilience workers. And these are folks who are generally, they're not necessarily social workers or psychologists, but they may be usually college prepared, but they are also people who will identify folks and do home visits with them around their diabetes or control their diabetes and address many of the social determinants of health that many of these folks require. So those are some ideas. Anybody else have any other ideas? Is that something that ring anything for you, Emily?
Yeah, I think that is definitely helpful to think about, and a lot of that stuff is actually happening in this community. We're just not necessarily, they're not on our team, so it gives me a couple people to reach out to as well.
Right. It's I think that what I discovered when I was doing group visits in the volunteers in medicine, I mean, this is a population that generally wasn't accessing the healthcare system, that the usual clinics. It seemed that they felt that the population of folks felt more comfortable coming in for these group visits. Many of them, they were peers for the most part, and it seemed to be less anxiety-provoking and for folks, as opposed to trying to set up an appointment, being on time, and then maybe the clinician not being on time, and there's a lot of stress around that. So you have to, I think, thinking about where are those places that folks, where you might have a chance to engage them that we don't normally think about.
Yeah, thank you. That's very helpful.
Any other suggestions or? So where are the other? Can people share a little bit about what other kinds of strengths? It sounds like you might have some community health worker resource. How about chronic? How about living well classes? Are those?
Yeah, at INHS we do Living Well, and I believe that Chaz has some Living Well classes going as well. If anybody else does that, I don't know about it, but we definitely have Living Well with diabetes, Living Well with chronic disease, and Living Well with chronic pain.
Mm-hmm. Great.
Does anybody else out there have anything that we don't know about?
I would say at our Yakima Valley Farm Workers Clinic site in Spokane, we're doing the Tomando Control chronic disease management course, which is taking control. So there are many different models out there, but that's one of them that we're utilizing.
That's great and helpful to know, because every once in a while we'll get requests for that as well.
I'm curious to know whether the driver diagram would be helpful to you all in terms of thinking and in your planning. I know that a very practical thing here is that you all need to come up with develop an application, and we found, so as a physician, I get lost if anything is beyond 2 pages, right? So it's always good to try to keep everything on 1 page. I know this is a really busy driver diagram, but it does help as a communication tool to others and to the staff. I think, is this something that looks like that could be helpful? Is there a way in which we can help you with this?
I personally think it's helpful, and I'd be interested to send it out to the team as well, and just see if it gives them any different perspective on the work that we're trying to accomplish, because I think that's the diagram I was looking at when I started thinking about the patient engagement. So even just one little, if it just reminds people of one little thing that could help add to our plan, would be great.
Right. Yeah, and I just, these are just my ideas. I'll just tell you folks, I'm not telling you this is what you need to do. I listed things that I, through the 20 years, seem to really make a difference, and quite frankly are change ideas that many clinics are currently participating in. So, it's hard to find an integrated clinic anymore that isn't doing huddles, for example. I think the importance of having, care managers, certainly in many of the practices also have a dedicated role to a care manager in the practice or the clinic, and then kind of a coordinator maybe in the larger, maybe at the collaborative level, but certainly at the practice level, somebody who's really focused on that registry and knows who those 10% of folks that are the maybe the highest utilizers or have the most needs, and really staying focused on that group. So I'm at the end of time here. Please feel free to reach out to me. You can get in touch with me through Justin or the folks at BHT. I'm always happy to talk with you offline. or in person if needed. But my best regards to you all and best wishes as you put together your plan. This is such important work. I'm really enthused about it's hard work. I wish this was easier. There are a number of elements, there are a number of levers that we all have to pull, and that increases the complexity. We can't deny the fact that it is complex, but we sometimes make it maybe more complicated than it needs to be. And so whatever we can do to try to simplify it, but try to address these things, I think and we have evidence now that it does make a difference. So best of luck to all of you. So I'm going to finish with that. Thanks. All have a great day and a great week. Back to you, Justin.
Thank you, Ron. For the callers, we're going to have this webinar recorded and posted on the BHT website quite soon. So thank you for participating, and we look forward to sharing more information.